everyone. My name is Jesse Chason with Lisa Blanchard as the host of Airing Addiction.
I share often my journey started on this campus. Got sober as a client here, just like you.
I really do see phenomenal change.
Always hope. I've seen situations that on the surface look impossible become possible.
Doing this podcast is to share those recovery stories, be honest about what the challenges are and have some real conversations, but kind of share that out on the airwaves.
Welcome everybody to Airing Addiction. Hope you're well listening to this, however you are consuming it, if you're watching live on Facebook or later on your favorite podcast option. We are in our last week of Recovery Month, so just a brief recap. We've had some great lived experience guests, as well as guests from the community, and exciting things and programs that are happening right now in the recovery community. And to wrap up our Airing Addiction, we have two phenomenal guests today that Lisa are going to introduce.
So much, Jesse. So happy Recovery Month. As we've said before on this podcast, the SAMHSA puts out this Recovery Month and has a focus on every person, every family, and every community. And we've had a lot of discussions about individuals in recovery, about peer support, about families with our podcast with UMass. And now we actually are going to probably talk a little bit more about communities. And so I'm really excited to have our guests on today. We've been talking about having them both on the podcast for some time. I've been doing some fantastic work with them over the last couple of years that really have gone by very fast. And so I'd love to introduce both Dr. Rick Altice and Dr. Lynn Madden to this podcast. So Dr. Altice is a professor of medicine, epidemiology, and public health at Yale University, where he is the director of clinical and community research, the community healthcare van, and HIV in prisons program. So he has a lot of implementation science experience, both locally, nationally, and internationally. And so there's some really fantastic work we can talk about today. And Dr. Lynn Madden is the president and CEO of App Foundation, assistant professor of the Yale School of Medicine AIDS program, and has really done quite a bit of work. And I've known her for quite some time now, I think over a decade, looking at gaps in substance use and mental health treatment, and has done a lot of work around integration with primary care and infectious diseases. She's also a NIATEX coach, which is how I know her, because I have been a coach myself for the last 10 years. And that's how I've really gotten involved in one of their more recent projects. I think you've got a lot going on at all times, heading to Peru at the end of the week, and lots of fantastic things. But welcome both of you so much to the podcast, Rick and Lynn. We really appreciate you being here. I wondered if you wanted to start us off just even with some general thoughts about kind of your approach to your work and how communities and how policies and systems might actually impact those with substance use disorders, and even the current the project that we just wrapped up a couple of weeks ago.
Yeah, thank you, Lisa, so much for the invitation. And I want to start by saying, that I appreciate and honor all persons who are in recovery. And I'm really happy that you've chosen today to focus a bit on community. Before I just sort of turn things over to Rick to describe our current project, I would say that one of the principles that we both work from, and that my work has been informed by, is that people who live with substance use issues don't live alone, and that they have people who love them, they have effects on communities. And I think that conversely, they're also often very isolated. And so I think that part of the work is to think about individuals as whole persons, and to also give people credit who are living with substance use issues for their pro-social decisions. So many people make good decisions about various aspects of their substance use, choices that they make along the way, whether that be to enter treatment or to move or to move into recovery in a different way. And I think that, interestingly, people don't get a lot of credit for that. So without really talking too much about the work, I would offer that as a frame. Rick, I saw your chat. Are you back? James, it appears that Rick doesn't have any sound. Okay, so I'll just babble on then until I get the high sign. How's that? So the work that we asked Lisa to help us with, and that she, of course, did her usual terrific. I didn't hear what you said. Did her usual terrific job with, was it's a HRSA grant. HRSA Special Projects of National Significance. And the grant was about strengthening systems of care. And so we, as a team, great, I see you're back on, Rick. I was just launching into describing the HRSA project, and I wonder if you want to take it from there.
Sure thing. So I also echo Lynn's statements around how important it is for communities and the recovery process, and how things don't exist in isolation. But the project that we worked on was really about looking at communities across 5 states. And it's really with the recognition that there are a number of intertwined and overlapping epidemics: HIV, opioids, hepatitis C, mental illness, incarceration, disruptions of communities and families, and other things like that. And so we really took on the notion that we wanted to try to figure out how to sort of scale up evidence-based treatments that really address both HIV and opioid use disorder. And so we tried to understand the landscape, understanding what was happening at the state level, the communities within healthcare systems for patients who were engaged in the system. What were the sort of legal landscapes that sort of undermine the ability to scale up these evidence-based practices? And we worked together with sort of key stakeholders in various different communities, from the HIV Ryan White clinics, from the substance use disorder treatment programs, from the hospital systems, et cetera, and tried to take on a community approach to sort of overcome a number of the barriers in each of these communities, which the barriers were really quite different, some of them being in very rural settings. And you can imagine the sorts of barriers in terms of access and how to come up with sort of new opportunities to sort of address the epidemic, as well as strategies that were happening in urban settings, happening in various different touch points, such as harm reduction programs, addiction treatment programs, hospital-based systems, criminal justice settings, et cetera. And so we really took on that community. We had a community engagement process where they selected the strategies that they thought were most relevant to them. We let them use their own data, which we helped them generate, and so that they could actually guide some of their innovations. And it was really extraordinary, I think, when we sort of speak at the community level, how resilient and how resourceful communities can be when they do come together. And Lynn, I know you have a lot of ideas about some of this work, and maybe perhaps want to expand on some of that.
Yeah, I mean, I can go on into that. One of the more fascinating issues that we did uncover is that the various kinds of data that Rick is talking about, in other words, how many people need treatment for a substance use issue versus how many people are in treatment, how many people have HIV or viral hepatitis in a given population, that kind of data is not readily available to people who plan these kinds of services, particularly when you think about looking at those 3 strands of data together. Right, so there is clearly a big overlap between persons who use drugs and HIV and hepatitis C. Sometimes a person may be living with all 3 of those conditions, but yet from a public policy perspective, there's not a great understanding of the scope of that overlap, nor are there strategies that are, generally speaking, designed to address sort of that syndemic or whole set of issues on behalf of an individual or a community at the same time. And, at some level, that's kind of a real lost opportunity, right? When a person walks through a particular door, whether that door be a treatment program, the carceral system, a primary care office, they should be able to at least be screened for each of those issues simultaneously. And if they screen positively, at least be informed about what their choices and options actually are, right? But in our country today, those kinds of care are generally funded separately. People are not necessarily trained to be looking at the person, if you will, in a holistic way. This perhaps is particularly true when we get to certain systems like community custody systems or the carceral system in general. They have other priorities, right? I mean, so just the whole set of ideas that we are trying to bring to the table, that a person is only one human at a time, and that it's in the best interest of that person and the community at large to be looking across the landscape for that individual and for the community, so that we can make the best choices that we can under the circumstances.
So there are a couple of parallels I'd love to point out, right? So because, we do this podcast and we share stories of lived experience, and we share experts or issues related to the field, that there's a lot of parallels to the work that was done in that HRSA project of looking at the community kind of like you would look at a person in need of support, right? So it's very similar, when you meet, when Rick described meeting with each kind of state and having key stakeholders and letting them determine kind of what are the goals we want to work on, what are the ways in which we want to impact this, what makes sense for our state, for our community. There's a lot of parallels to when you meet with somebody clinically, individually, and say, what do you need as a person, right? What goals do you have versus what are my goals for you? It really kind of strikes me that it's, very similar to a person-centered treatment plan to kind of a community-centered, treatment impact approach, whatever we would want to kind of call it. Can you talk a little bit? And I know it's inherent in a lot of the work that I've done in process improvement coaching, but why it was so important for you to let the states and the communities kind of drive that path versus coming in and saying, here's what we know works. Here is a cookie cutter system that I just want you to put in place. Like, why let the community do it themselves and decide what path to take?
Yeah, I would just point out that one of the things that one of my colleagues said as we were doing some work in New Haven is that, we oftentimes think about, as you pointed out, Lisa, that the patient who's in front of us is who we treat. But I think what you're really pointing out to is what she said is, she says our patient is our community. We have to sort of think very broadly about all of those sorts of things. And I think that that's true. And what's really emerging from that kind of thinking is what's really happening at the national level about thinking about community-based engagement strategies, and to really sort of think holistically, about the community. And, part of what can happen when the communities are engaged is that they can go down pathways that do help them in the same way that our patients do, and they can go down pathways that don't help them. And so in either one of these choices, what is really evolving with that is using data-driven strategies. And so making sure that the data are available. And I think, as Lynn pointed out, the data in this kind of setting are not available. And when they are, they're very siloed and they're not interrelated and connected. And so I would say the next generation of activities really involves a community engagement process. It should be data-driven. And given the data, communities should prioritize those things that they're able to sort of, begin to address, most quickly. And they can make better decisions when they have better information that's available to them. And I think that was one of the sort of the walkaway sort of lessons from this, is that sometimes it did require some coaching, as you know, to sort of keep the communities on, this is what the data show. And as Lynn loves to always say, the data is our friend. And the data is not judgmental. It's just the data. And so to really work with that. And I think that Lisa and Jesse, that in your own sort of day-to-day operations, much of what you're doing in your sort of work is being able to help folks make better decisions, and that's what we were really doing with the communities. And I do think it will represent sort of an evolving way of thinking about how to address these really large problems that do cross over communities and even in our setting across different states, but where there can be some common learning lessons that you can bring back to share with each other in order to how to better tackle it. They do need some new ideas from outside that. And they need to see how other communities like them or not like them respond. And so I think that was really, a lot of the enthusiasm and the things that I learned, from the process to sort of, reach a little bit further out. And I do think that, there certainly were, many successes that came from this process. But I also think that communities began to learn and they began to be able to sort of self-sustain once they got some of this information together.
Yeah, I love the analogy, Lisa, that, the analogy of the community to the person, right? So you're kind of moving from individual, if you will, out a bit into maybe into a family or then into a larger community system, right? I think that's just a really excellent analogy. Part of the challenge really, I think, is always to function from a strength-based place. So that, again, is the same idea as working with an individual person. Communities all have strengths, and trying to help them uncover what those strengths are is one of the reasons not to go in and say, here's the solution. Right. At some level, as Rick's pointed out, we know what some of the evidence-based and science-based solutions actually are. There are lots of reasons why communities haven't adopted them. Right. And trying to help those communities figure that out is part of the work. I do think that there's a kind of informed consent process that takes place here, right? A lot of communities simply are unaware of the connections between substance use issues, the health of the family, the larger health of the community, specifically hepatitis and HIV in this particular example. And when that data is provided to them, and perhaps kind of the pathway becomes a little bit more clear using some of the coaching tools that we have about what you can do next, I think that becomes a way of, first of all, moving in the direction that you want to be moving in, but also building confidence in these community coalitions, right? So many community coalitions meet and feel, I think, at some level as if they're spinning their wheels because they don't see kind of measurable progress. Yet they probably are making progress on some fronts. It's kind of learning how to focus on where you want to go and then showing yourself that information over and over again, I think it is a real strength of this particular approach and becomes a way of seeding the future for continued positive forward momentum, right? Whether that's on behalf of a person or a larger community.
Thank you, Lynn. That's actually what I was going to hit on too. I love when Rick, you said our patient is our community, and I'm just sort of tripping out here in my own mind, thinking of all the solutions that I've observed as somebody in recovery that has relied on professionals in the field and their solutions to barriers, whether it be organizationally, statewide, beyond that. And I'm sitting here, somebody who has benefited from those workarounds, if you will, that there's a solution to every problem, and maybe there's something that we can't yet do on a state level, but if you drill down to the individual agency or even individual clinician or case manager or recovery coach, something that professional has found to work for them. I'm wondering if there's one or maybe more of those. Rick, you mentioned the enthusiasm that you observed when working and engaging with these communities and helping them develop their own solutions, if you will. If there was one or more solutions that you observed with your HRSA grant work that has stood out to you that maybe could be replicated or duplicated across agencies or even across states as applicable?
Yeah, so I think that, one of the things that sort of resonates around, the whole process is as you begin to sort of offer up ideas or they hear solutions from other places, just like for people who are moving into recovery, it's that aha moment. They see other things that, work, and sometimes there are things that, at least initially are rejected as potential ideas. And one of the things that we observed, and we actually had to go and prove it on the data, was the idea of how do you sort of reduce demands, on patients, especially during the COVID pandemic. And we were working in the midst of the COVID pandemic, and we would work with these, communities, and they were all struggling. And, from a community mitigation strategy, they didn't really want or need the patients to come into the clinic, on a regular basis for, counseling appointments and things like that. But on the other hand, they were really struck with the idea that there was a prescribed way to do addiction treatment. The patient must come in, they must be seen, they must have a urine toxicology test and all this. So they were sort of met with a disruption, if you will. And the COVID did that to a lot of things in all of our lives. But one of the things that I did see is that, when presented with the data, including from their own states, that sort of freeing up the demands on patients and the clinicians for that matter, really did make a difference. And the communities would share that information with each other. And of course, they had some anxiety about doing that work. And I will say that there was really a parallel for that, which we observed while we were working in Ukraine, where, this is a place that has much less resources than here in the US. And they did respond to, some of these various different activities, and each community, accepted it and adopted it differently. They were faced with the idea that they were going to free up the patients, and that they were going to harm themselves by overdosing and things like that. And we were able to really use the data and to turn back and say, okay, people did not get harmed. And as it turns out, if you don't have to make it to the clinic and drive your car and get through traffic, and as our friend Judith Feinberg says, didn't have to spend 2 hours behind a logging truck in a narrow road in West Virginia, that, to get to your appointment, that you actually can, take care of other things at home and take your medications and do fairly well. And you can check in by phone and also do well. So I think that that's one of the lessons that I call the aha moments, where communities were somewhat resistant to that. They were afraid, not only from COVID, but from, the safety of their patients legitimately. I mean, these were all legitimate concerns, but they actually used their own data to sort of see how to do that more effectively. They found out there were no additional harms, and it actually benefited the patients, and it in many ways benefited the clinicians, who had more time to focus on bringing new patients into treatment. So that would be one of the examples that I would use. I'm sure there were several others, but that one is the one that stands out most, I think.
Yeah. I mean, I think all of the states that were involved in our HRSA grant did something slightly different. As Rick said, one of the key aspects of some of the work that Rick and I have been doing together over the last decade, really pretty much at this point in many, many places in the world, is this idea that you can reduce demands on the individual and therefore make it easier for that person to navigate into care, right? Or to stay in care. So if we make that front door open really wide, and we simultaneously at the front door really give people useful information and do useful things, right? I'll give you an example of that. One of the things we have a tendency to do at the front door is collect this massive history from people after we've perhaps made them wait for an appointment, right? And we're asking them all kinds of things that we have to know based on regulatory structures, perhaps, before we actually let them tell us why they're there. Right. So one of the challenges here that we've put before organizations and individuals is, what do you really have to do in that first few minutes? Couldn't you just ask people, why are you here? What can I do to help you, before you find out how many siblings they have? right? I mean, there may be a way of really structuring the front door so that the immediate needs of the individual are met in real time, which I think is important. That individual then gets the message that we care about them, right? So this can happen on an organizational basis. This can happen on a community basis. We've actually seen it happen on a national basis. You have to give people the message that you care about them. And part of that message is really giving them straight information from the beginning. Oh, I see that you're a person, you just let me know that sometimes you've injected drugs. Well, how about today you have a blood test for hepatitis and HIV, because that is commonly associated with injecting drugs. No, it's not really going to cost you anymore, and we'll give you the results tomorrow when we see you, right? I mean, there are ways of treating people as if they have agency and not infantilizing them, and honoring their choice to actually walk through the door and making it easier for them to walk through the door and meeting their needs in real time, that I think we can do on a much wider scale, right? And that to some degree is what this work was about, is really integrating these systems of care, sort of braiding them, if you will, so that both clinician and the patient, along with the larger community, get the message that there's more than one important thing happening here, and that every choice you make has a wider impact on not only yourself, but on the people you care about, and the community at large.
And I'll build on that a little bit. And it's, I think, one of the observations that we've made in working with agencies as they do this, and that is that when you open that door wide open and you sort of try to understand what it is that they want and try to get that for them, that what that does, and by just also changing that process, is it reduces stigma. And in many cases, it's intersectional stigma, because it basically says, we're not trying to put up a barrier. We're not trying to have you prove that you're deserving of treatment or that you're motivated for treatment. If you were showing up at the door, you're really probably wanting to get some treatment, whatever that might be. And we tell you that we want to make that happen. And it rearranges and reduces the opportunities for introducing stigma in the healthcare setting. Yes. And that has been an observation that we've heard time and time again, that and it's not really sort of listed as one of the evidence-based stigma reduction interventions, but I think indeed it probably is. And there's a whole field in psychology called behavioral design. And these behavioral design of reducing stigma by rearranging the way that things are done, and providing nudges for providers and things like that is I think probably part of the future. And it really needs to be applied generally to all healthcare, but certainly for individuals who have these overlapping and multiple layers of stigma, where these intersectional stigma factors are really going to keep patients either out of care or keep them from being retained in care. So I think that that's been a really big sort of learning lesson, and that actually will go a long ways to sort of reduce community levels of stigma. Once that starts to happen at that individual, they have families, they have networks, they have friends. It opens up the door for other people to come into treatment. So I think that's been a big learning lesson that we've had in doing this work.
I love the approach, and I've been doing a lot of work, at Spectrum and Recovery Center for years and years, and Lynn knows a lot of this, right? Of really, reducing barriers, low barrier access, medication first, because there's not really anywhere else in healthcare where you ask individuals to really, like you said, Rick, prove that they really want this, that if you jump through these few hoops, if you make a call to this treatment program every day, 5 times a day until you have a bed open, then that shows us you're actually ready, that you've kind of hit that rock bottom, that you need that at this point. There's nowhere else that we do that. We try to intervene earlier and faster to prevent acuity in really all other settings, except for that still exists sometimes in addiction treatment, when really we can help people wherever they are at any point, right? And they're just as valuable at any point as they would be, if they were ready to the point that, the system wants them to be ready, in 6 months or a year.
Yeah, I think it's so fascinating that you bring that up, Lisa. I couldn't agree more. It's the only healthcare specialty, if you will, where patients, before they're even in the system, so persons, we're going to call patients, are supposed to know what they need, right? Nobody calls a surgeon and says, I think I need a cardiac bypass. I mean, it just does not work like that. We don't force people to diagnose themselves in other kinds of in other arenas of healthcare. And when they do enter the healthcare system, as you point out, we're trying to prevent further harm, but we also tell them what we think is going on. Right? I mean, the whole purpose of evaluation is to say, hey, here's what I think is going on, and here's what your options actually are. We flip that whole thing around in the design of the substance use treatment system. You're supposed to know what you need and want, and people don't. And why should they? Right? I mean, at some level, what they want may be something as straightforward as, I don't want to lose my kids. Right? That is not the same thing as saying, I think I need this level of care. So I think that's a fascinating kind of, challenge that we have before us, to be welcoming, as Rick is talking about, to be low barrier, to ascribe value to the individual by designing a system that actually makes them feel valued.
I really had this interesting experience this past week where a very dear friend of mine, it's unfortunate, but he was diagnosed very quickly with a tumor. And it was interesting. He was describing the healthcare system. And they said, this is a fast growing tumor. They had a SWAT team. And within, less than a week, they had this person completely evaluated. And on, treatment almost immediately. I mean, it was incredible. And if you think about, addiction, especially with the fentanyl crisis and the overdose rates and stuff like that, we really need to be thinking about that in the same sort of way. We should have a SWAT approach where we get them in the door, we reduce the time to treatment, and really focus on the emergency that is upon us. A person just doesn't present and then saying, okay, this is, I can hang around and do this. I think that given the current, sort of landscape, that we don't have that option. We probably never did, but more so than ever. Every day that person goes home is another day that they get to go to heaven, potentially. And so we really need to be rethinking about this as sort of really an individual and a public health emergency, and coming up with ways, as that was just sort of stated, about opening up that door and getting them in, and to reduce stigma in the process, is really how we have to think about this. There should be no waiting list ever.
Thank you for saying that, Rick. I'm reflecting on my own lived experience as somebody with substance use disorder and somebody who has received services from Spectrum Health Systems, and coming from an incarceration situation, and all the barriers that, like I hinted at before, just had to be navigated in a certain way by the trained professionals who were there at the time. And thank God for them, because if they weren't there, those barriers could have very well prevented me from seeking the treatment that I so desperately needed, and has benefited me for the last 14 years, up to and including this podcast and this opportunity to speak. And, one of them, just to put some practical application into it, is you talked about, intersectional stigma, and based solely off of a 5-minute conversation. And this is no fault of this guy, but it was a fact that, based off of this very brief conversation prior to getting on the phone to actually calling Spectrum Health Systems to do my regulatory intake phone call, this gentleman already assessed me and deemed me to be not worthy of service, and actually told the Spectrum employee on the other side of that phone, you don't want to take this guy. You wouldn't like him. I did not overhear that statement, and I did not know that until a full 13 years after the fact, that I happened to work with the woman who's on the other side of the phone. Now she's a colleague and a friend, and she told me that, and I was blown away, because in an instant, my life as it is today, presently constructed, disappeared before my very eyes. Because had that person just taking that colleague's word, that could have shut the door right there. So I could go on, and I don't want to, because I want to hear from both of you about maybe some ideas of, not only how to combat that stigma amongst treatment providers, but also, you mentioned a SWAT approach, Rick, to your friend's situation with the medical tumor. What type of SWAT approach do you believe, based on the data and based on all your work you've done, we can be doing as professionals? Or even, if someone's listening to this, that, very commonly we hear loved ones of people with substance use disorder listen to this podcast and engage with our family support services. What type of SWAT approach would you recommend, or do you think would work in this situation?
So, Jesse, first of all, thank you for sharing your lived experience. I think that will resonate with many people who've been, at part of the system, either as a clinician or as a patient. So thank you for sharing that and putting a real face and a voice to that issue. I think that it really requires a rethinking of, the way that services are. And the services should not be looking at ways to exclude patients from treatment, but to overcome the factors that may exclude them, whether it's insurance or any of those other sorts of things. So the idea should be the person who presents it at your door is going to get treatment, and you're going to do the X number of things that are needed, whether it is to put them onto treatment for 3 days while you're working on their paperwork to get Medicaid. I'm just giving some examples. If that there's a transportation issue, that you have a SWAT person who's, sort of making sure that there's a sort of a mechanism to overcome, sort of transportation issues. When that person comes through the door, if they get, you think about it, you have a cough and a fever and you go into the doctor, and you'd like the doctor to give you something, right? You'd like a prescription when you walk out. When people walk out, they walk out disappointed that they didn't get something. And I think that that's exactly what we should be thinking about. Not that everybody needs exactly what they want, but if they're needing treatment, they should get treatment. Sometimes that treatment doesn't always look the way it is, but to really say that is going to be the goal. And if you start from that goal setting, whether it's at the organizational level or at the clinician level, but the goal is to get the person onto treatment as quickly as possibly can, and that these are the 7 barriers or the 3 barriers or the 1 barrier that's needed, that those things become your SWAT team activities. And Lynn has done this in real time through, sort of an agency, and I'm sure that she will actually add to this. She runs a large organization and thinks very, very strongly about and with great detail about how to do this.
Yeah, I think it's a great question, Jesse. The whole idea of what does it really mean to treat people with substance use issues in an urgent way, right? And I think first and foremost, and I've spent 2 decades saying this, and I really welcome the opportunity to say it today, there shouldn't be appointments. There need to be places where if you think you need help, you should be able to walk in. And we have such a place called emergency departments for virtually every other kinds of, urgent issues that persons have. So one thing we can do is rethink very dramatically the role of the emergency department. I think the other thing is that no agency should be making appointments. There is literally no information that suggests that one-on-one appointment making creates better outcomes at the front door than just staffing yourself to receive all the persons that come in, right? There's a whole theory about all this, what I get very excited about from an engineering point of view, called queuing theory or line theory. The reality is that wait time is just inherently inefficient, and making appointments is inefficient. And back to something we were talking about a few minutes ago, it gives people the impression that what they think they need and want is not important. Well, the reality is that people are dying, right? The equivalent of a large plane of people is falling out of the sky every day in the United States, every single day. That's the extent of the overdose problem in our country. That's the people who die from overdose. There are 30 to 40 persons somewhere in our communities who are overdosing at that same time every day, times that number of about 250 people a day. That's a lot of people who are in distress. What is the community response as part of the SWAT question, and how can it better meet those persons' needs, even if all we do is save their lives, right? If you draw the triangle, the important thing is don't die. Don't die, because really a lot of people get better, and you will too, if we can just keep trying to figure out, what would help you walk through the door. So walking through the door and not having a lot in the way between you and good care is important. But I think also backing that up a little bit, what would help people seek care more readily? Right? How can we reinforce this idea that we care about you not dying or not contracting other illnesses and diseases, that we actually care about you? What would that really look like? Right? And that's the kind of SWOT approach. I mean, we make everyone wear a seatbelt, don't we? Right? I mean, there are lots of social engineering examples that we can point to out there. What are ours when it comes to the world of substance use? How much do people really know? What do we provide them with for resources? And how do we really make it easy for them to navigate into treatment, as Rick was pointing out?
Yeah, I wonder if, you did such a great job describing kind of making the door wider. And I think this project even showed us that what if we just remove the door, right? What if we just go to where people are and they exist in their community, right? So unfortunately, we know that this, needs to change, but that a lot of individuals with substance use disorders, as Jesse clearly described with his own experience, end up in the criminal justice system, end up incarcerated. And so a lot of the work that we did was, let's just bring the treatment directly to where you are, and improve that screening and access to care. One of the projects we worked on was working with harm reduction programs. So where we're interfacing with you anyway to give you things that you need, that you're looking for. Let's also offer treatment. Oh, and you don't have to even walk in a door. Here's a phone. Just make that phone call and we can start this right now if you want to, right? So, that's really kind of just taking the door off the hinges completely.
Yeah, the door is a metaphor, right? I mean, really, where do we meet you and what do we offer? I think is a question.
Yeah, Willie Sutton, the famous, bank robber, was, asked why does he keep, robbing banks, and he said it's where the money is. All of these places that you've just talked about are touch points where you can actually find and take the opportunity to get people where you don't have a door to come in and get treatment.
Yeah, and another
that's exactly how we have to think about it.
Yeah, the other analogy is really full court press, right? We talk about the urgency of substance use issues, but I would suggest that there could be a full court press here that's not actually underway. And it's certainly not underway in any kind of wide way, right? There are organizations, communities, individual persons who are, giving their all, doing the full court press, thinking outside of the current paradigm all the time. But that is not yet our national response, right? Really, we can do better. And I think it's incumbent on us to continue conversations like this one, like, how do you do better? And partly, I think it's trying to do that upstream thing. Where are these folks? Who are they, right? We know who they are. They're us. How can we get to them in ways like everyone gets their kids' teeth cleaned if they have a way to do that? Like, how do we do the kinds of work that is related to being able for an individual person to have agency over recognizing that perhaps they're getting into difficulty with something and really letting someone else know that, right? Without feeling ashamed of that. How do we do that?
Exactly. And, a saying that just keeps resonating with me. So I just need to say it to both of you. Is something I heard early on about, addiction is no respecter of persons, regardless of socioeconomic status or community. And, maybe the stigma looks different from your traditional urban setting where, the vast majority of people live below the poverty line, to the sort of, idyllic white picket fence of the suburban community where addiction is held behind closed doors and nobody speaks of it because of the fear of what people would think. And a saying I heard early on was from Yale to jail and everywhere in between. I figured you guys would like that, right? It doesn't matter, what the circumstances are, what the, I know people who, from the outside look like your average American affluent, very well off financially person that are struggling with substance abuse behind closed doors all the way to, myself. I shared where I entered the system from, and thank God for those barriers that were overcome. I was someone who didn't have insurance. So I came into Spectrum Health Systems on a bed that was subsidized from the Bureau of Substance Abuse Services. And that same woman that was on the other end of the phone when I got there helped me apply for Mass Health. Right. So from Yale to jail, everywhere along the way. And, as we are sort of coming to a close here, I just didn't want this episode to pass without sort of paying off the little tease that we hinted to at the beginning. Both of you are taking a trip in the next week or at the end of the week. And I'd love to hear, and, our listeners, I'm sure, would appreciate what that entails and why you're going there.
Yeah, we're going to Peru. I'm going to let Rick describe that. I want to, which is very exciting and mirrors some of the work that we've done in other places, and also is a little different to the expressions that people are coming up here. I was watching, I just want to say, because this always reminds me of Rick, I was watching Maine Cabin Masters over the weekend. Okay, so if you haven't watched this, you have to watch it. I'm originally from Maine, and there's one of the guys on there, and he's a carpenter, and he says a lot. There are no problems. There are only solutions. No problems, only solutions. And he just says that to himself over and over in the show.
So just regarding Peru, it really is sort of building on the same notion that we've been doing with addiction, but now applying it to the HIV world. Solutions, there are solutions. And it's interesting, the solutions from addiction, we're really going to be applying, to Peru, where they have got this major problem. So if you think about barriers, they have these huge HIV clinics, 5,000 people, and they have to make appointments, and they have to spend all day, and they have to do all these sorts of things. And what that does is and this will sound familiar, they drop out of care. So they're not retained in care. And so what we are doing is we are doing some work around helping communities, the city of Lima, which is a huge sprawling city, sort of come up with community-based solutions to sort of move the HIV care into these community districts so that people can get their services closer to home, because they spend, several hours and untold amounts of money sort of navigating the city to be able to get into care, but to also do this in a safe and responsible way. And their communities are coming up with the ideas about how to do that. And so we did a lot of background work in order to prepare for the activities. And we're actually making our first on-site visit to start engaging with the communities, building a community coalition process, getting stakeholders to prioritize what's important, to set goals, which is really important, and to work at how to decentralize, these services. So it is not necessarily addiction, but it should resonate, because it's the exact same problems that we have in urban communities all over the world with regard to treatment, and it will hopefully democratize the way that people can get services.
Well, I just want to say, I think a great way to wrap this up is with some gratitude. So often, really, I don't think we've had a podcast episode where we didn't discuss hope. And I think all of the system implementation work, all of the work that you do, really does generate hope that we can do things differently, right? We aren't stuck with the same responses and the same challenges, that we can change the system and get a different outcome. And just really a lot of gratitude for you both for all the work that you do locally with individual people, with systems, with states, nationally and internationally. You're really making a big difference. And thanks so much for coming on the podcast to talk a bit about it.
Thank you so much for the opportunity, Lisa and Jesse.
Thanks as well. And as you would say, hope springs eternal. It is.
Most definitely. And thank you both. This was a pleasure to hear from both of you. And I second Lisa's gratitude that, there's someone out there right now may or may not be listening to this, but it is going to benefit from the work that you both are doing on a systematic level. So thank you both. And thank you everyone for listening. We will be back next month with a fresh episode of Airing Addiction. If you like what you heard, you can get it at any podcast location, like, subscribe, all that fun stuff. And we will talk to you soon. Thanks, everybody.
Happy Recovery Month.